So there's a basic concept that I need to get across to you today. We used to think that if we were basically predetermined to get a particular disease, let's throw that out. That may only relate to these specific diseases: Huntington's disease, cystic fibrosis, Tay-Sachs syndrome, sickle cell anemia. The rest of the chronic diseases like heart disease, osteoporosis, cancer, or immune dysregulations relate back to these SNPs, these single nucleotide polymorphisms. So the new paradigm is that genes predispose an individual to a disease. And it is this where we come into functional genomics, because now we can see the potential here for lots of specificity when we work with a patient in our office. If you work with somebody who's been adopted, we have no idea of their past history. So they are prime candidates to do this kind of testing. Another candidate would be somebody who wants a really specialized and individualized nutritional program. Because once you get this information, you can give them specific dietary and nutrient recommendations for their individual prevention or treatment program. We can look at drug-drug interactions. We can look at gene-diet interactions, which I'll talk to you about in just a minute. And we can look at the possibility of customizing a disease prevention or treatment program based on your unique DNA. Quite empowering for a lot of people, including the practitioner, because now you have data that you can share with this individual that is their own. We have so many times, at least in the nutrition literature, where a particular individual or test will be done based on epidemiology studies looking at, say, folic acid. And folic acid, unfortunately, is one of those nutrients that has a SNP associated with it. For those of you who are going to be here tomorrow, I have an 8 o'clock presentation on using this information as it relates to heart disease. For those of you who are working with people who have elevated homocysteine levels, that usually indicates a vitamin B deficiency. It also indicates that they're probably not utilizing that folic acid from their diet or from a nutritional supplement, because they have a SNP on the ability to convert tetrahydrofolic acid to 5,10-methylene tetrahydrofolic acid. That's an enzyme. There are testing now available to identify those individuals. I was one of them. I've done my genomic test. I was one of those. I had an unexplained homocysteine level that was 12.7. That's outside the normal range. The physician that I went to go see said, "Are you taking B-complex vitamins?" And I said, "Of course." And he said, "Well, I don't know why it's elevated. Take more." Well, the problem was that I had a SNP, a single nucleotide polymorphism. That gene was not making the enzyme to convert folic acid to its downstream metabolite. By understanding that particular piece of information, then I was able to circumvent that, and now my homocysteine level is 5.7. So this is an example of where you can use this information to specifically come up with a strategy for an individual when they have a biomarker that is outside the reference range. I'm going to get into personalized medicine here in a moment, and one of the reasons why personalized medicine came into existence was, as I said earlier, there are many, many, many thousands of people in this country that have adverse drug reactions. And most of those drug reactions occur in about 50% of the population that take drugs. It's known that most drugs have side effects. Yet there's nothing that we can do about that. This is a document that was printed by the FDA showing that in 2004 there were 400,000 people who had adverse drug reactions. That was 4 years ago. So I suspect that it's probably closer to 800 to 1,000 to 1 million. The response to drugs can vary for a lot of different reasons. The first one has to do with the drug metabolizing enzymes. How many people are familiar with the term detoxification? Good. Are you aware that there are 2 phases of detoxification, phase 1 and phase 2? If you are not aware of that, I would suggest a couple tapes by Jeff Bland. He has the Functional Medicine Institute in Gig Harbor, Washington. About 10-15 years ago, he put together a great tape series on how drugs are metabolized in your body through phase 1 and phase 2 detoxification.
What's the last name?
Jeff Bland, B-L-A-N-D. Phase 1 detoxification has to do with about 50 different what are called cytochrome P450 enzymes. For those of you who are not familiar with the biochemistry of detoxification, this is the first step. There are many, many thousands of drugs that have to get detoxified in order to get out of your body. Typically, they do not hang around and get excreted in your urine without some kind of biotransformation occurring in your liver and your kidney. So, depending on whether there are SNPs on the cytochrome P450 enzyme that is associated with that particular drug, you could have a problem and a consequence in a side effect. Physicians typically guess as to whether a drug is going to work or not. If you come back and report, I don't feel so good, then you'll say, well, we'll try another one. It's my contention that we can eliminate a lot of adverse drug reactions if we do this testing in advance. And there are some insurance companies today that are doing this. How many people work with patients who have Coumadin as a treatment for DVT or phlebitis or any of those? Typically, how long does it take to get that patient stabilized on Coumadin or warfarin? Sometimes as long as a year. Insurance companies are finally figuring out, the light bulb went off, and said maybe if we do a test in advance, we can actually eliminate the cost to the physician, to the patient, and to ourselves if we now start doing some genomic testing in advance. So these are where this genomic information is now coming into clinical practice. Except they're just looking at one of these cytochrome P450 enzymes. And if somebody is on multiple drugs, they're not authorizing genomic testing for the other drugs. So you get drug-drug interactions.